Our last speaker before the break is Professor Feras Abu Saadeh. دكتور فراس هو ابن المقاصد. Professor Feras Abu Saadeh, he is a consultant gynecology oncologist and pelvic surgeon at St. James Hospital, clinical associate professor at the Department of Gynecology Oncology, Institute of Molecular Medicine, Trinity, Dublin.
مساء الخير. السلام عليكم. لعل ما يضبط البرزنتيشن. I would like to thank Iyad, the organizing committee, for inviting me here. It's really my pleasure. I'm very happy to be back in Jerusalem. زي ما حكى الأخ بسام أنا ابن المقاصد. I did my initial training here in 2000 before I moved to Ireland in 2005. I have a great memory here in Jerusalem. اتعرفت على زوجتي here in Jerusalem, so I knew Nida shown here in Jerusalem. She was working in الهلال and I was working in مقاصد. So كان في قصة حب عظيمة. أنجبنا 4 أولاد, so I think it's a successful story. So for these reasons and many other reasons, this city means a lot for me. And also, before I start my presentation, I would like to thank Sean and Carmen for making all the hardship to come from Dublin to Jerusalem. I know how busy both of you, so really, genuinely, thank you very much. Now, when Iyad asked me to do a presentation for today, I asked him what's the theme for the meeting, and he said innovation in gynaecology. And my specialty is oncology. So I thought about different kind of cancers. And as far as I remember, the most common cancer here is endometrial cancer. So over the coming 20 minutes or so, I will focus on endometrial cancer in terms of epidemiology, staging, treatment. And on treatment, I'll be focusing mainly on controversial point on surgery, lymphadenectomy, adjuvant treatment, and I will touch quickly on new treatment and on young patient. So if you think of endometrial cancer, the prevalence is something around 30 per 100,000. So 30 by 100,000 doesn't mean anything really. But if you think in real number, in Ireland we have roughly around 350 cases a year. Ireland population is more or less 5 million, which is more or less like Palestine. Like when I say Palestine, I mean by that West Bank and Gaza. I don't mean historic Palestine. So you can think of endometrial cancer, you may have here around 350 cases a year. I think this is important from strategy planning and organizing how many gynae-onc center you need in the future, how many consultant, trainee, etc. Now, if you think as an individual, your personal risk of having endometrial cancer is something between 2 to 3%. The peak age in early 60s, and unfortunately, the risk is increasing. So early 2000, the prevalence rate was 20 per 100,000, but lately, late 2020, is something around 30 per 100,000. And if you wonder why, you just look how many McDonald's open in Jordan. We don't have McDonald's here in Palestine, alhamdulillah, lissa, but I'm sure it will come. So obesity is one of the main factors to blame for endometrial cancer. If you look at this world map back in 2020, it looks fantastic, nice and bright. ألوان وردية وجميلة وحلوة. It was the rate of obesity was something between 14 to 20%. But if you look at now, it's more purple in color. So endometrial obesity is something in 40s. So definitely we can blame obesity for the rise in rate of endometrial cancer, but we shouldn't forget other risk factors. Now, saying all of that, the good news, the prognosis from endometrial cancer is excellent. So for all stages, the 5-year survival is 80%. And for stage 1 is something 95%. And for certain type of stage 1 endometrial cancer, which I will touch on it later, it's almost 100%. So even if you have an endometrial cancer, if it's a certain type, you'll be cured from it if you have a certain genetic abnormalities. If we come to the staging, when I look in the history book, I find this is the first staging system back in 1953. وزي ما بوصفوه أحيانا في الفيسبوك العصر الجميل, the nice age at that stage. I'm sorry, this slide is over the place. Anyhow, the stage at that stage was two stages, stage 1 and stage 2. With the stage 1, cancer is in the uterus and operable. Stage 2, cancer outside the uterus and not operable. Now, the current staging system we use is this one, this from 2009, which look a little bit complicated. I agree with you, but it's pretty more or less simple. Stage 1 confined to the body of the uterus. Stage 2 move to the cervix. Stage 3 around the uterus, vagina, ovary, fallopian tube, and stage 4 have a distal metastasis. Now, if you think this staging system is complex, wait until you see this one. So this is the one which is suggested by FIGO in 2023. And honestly, I work on this field. This is the only thing I do, and I cannot remember this staging system. And I don't think anyone will remember this staging system. It's extremely complicated. There's a huge reluctance for most of the gynae-onc center to adapt it. Right now, literally right now, there is a webinar in the ISGO talking about this staging system. Should we adopt it or we should not? And I think what they try to do with this staging system, they try to give a personalized prescription for every cancer, for every woman, what kind of the most appropriate adjuvant treatment for the cancer. And I think this is where they fail. Because the idea from any staging system is not really to give a prescription for the treatment for the cancer. The aim from any staging system is really to describe the extent of the disease. And we can compare different centers and different outcome. And I think here where the guys in FIGO, they missed the boat. And I said there's a huge reluctance to use this staging system. And you know, if you think for up here, for example, they include metastasis to the ovary as a stage 1. In the old system, that was stage 3C. It's completely different. If you look here, stage 3, they have 3C1, 3C2, and that need micrometastasis. And you need a special pathology lab with a special pathologist who can pick up these micrometastases. So it's not really applicable in most of the centers. But if you ask me about innovation in gynae, this is the innovation on the staging system. Now on the treatment, I'm not gonna describe everything how to treat an endometrial cancer, that's well known and well established. But I'm gonna talk about some of the controversial points in management of endometrial cancer. So I'll talk about minimal access surgery, yes or no. About lymphadenectomy, should we do it or no? And about sentinel lymph node sampling. So if we start with the route of surgery, I think we moved from open surgery on the left-hand side, delivering such a huge specimen through a big midline scar. That's what was happening in 1980s and 90s, to the picture on the left-hand side, where it's 2 scars, 2 small holes with minimal access. So we moved from the picture on the left-hand side with an empty pelvis to a more conservative treatment with the picture on the right-hand side. Now, minimally invasive surgery is the preferred approach, including all patients, low risk and high risk. There's a huge evidence of randomized controlled trials supporting the use of minimal access in endometrial cancer. So that question is completely answered. I don't think anyone will open that question again. Now, if you're doing it with minimal access, try to avoid any intraperitoneal spillage of the tumor, either by making a mini laparotomy to deliver the uterus or put the uterus in an endo bag. So as I said, there's a huge amount of evidence. It's a randomized controlled trial back from 2010 and after. And I will show you these 2 trials. The first one, it looks into around 760 women. They randomized them into open or lab hysterectomy for endometrial cancer. And if you look at the Kaplan-Meier curve, on the left-hand side is the risk of recurrence, and on the right-hand side, a risk of death. And the 2 curve for the one with the yellow with the minimal access surgery and the one with the blue for open surgery, the 2 curves is almost exactly the same. So it's well established, there's no difference from oncology outcome between minimal access or open surgery. The other randomized controlled trial, which also published back in 2012, is the Lab2 trial. And that trial, they recruit more than 2,000 women, and they randomize them 1 to 2. So 1 open versus 2 with lab. And the Kaplan-Meier is exactly the same. So there's no difference between recurrence or mortality. Overall survival was exactly the same between the 2 arms of the study, either open or lab. Now, saying all of that, I think we need to take this with a bit of caution. I don't know if you remember back in November 2018, when this trial came out, and it's literally changed the practice of gynae-onc overnight. So up November 2018, we used to do all cervical cancer radical hysterectomy with laparoscopy. And then this trial came out in the New England Journal, and overnight, we stopped doing laparoscopic hysterectomy for cervical cancer because that was the Kaplan-Meier for this trial. So the odds ratio for dying from cervical cancer, if you have your surgery with laparoscopy, was 6 times compared to open surgery. Your chance of dying is 6 times just to have a minimal scar rather than having a traditional scar. And for that reason, overnight, we changed from minimal access to open, and no one now offers a radical hysterectomy for cervical cancer through a laparoscopic approach. Now, the next step, the next point I will talk about it is lymphadenectomy. And lymphadenectomy is one of the most controversial issues in gynae-oncology for the last 20 years. It hasn't been resolved, and I don't think it will be resolved for the coming 10 years or so. The question always to do it or not to do it. If you're going to do it, what level you should stop? You should stop here at the pelvic brim. You do para-aortic. And if you're doing para-aortic, should you go to the IMA? Or should you go all the way to the renal artery? And the big question really was, is there any therapeutic benefit for doing lymphadenectomy in endometrial cancer or no? So until early 2000, everyone was believing by doing a full lymphadenectomy, you increase survival for women with endometrial cancer. Now, the evidence for that was coming from this trial, which published in 1987. That's called GOG33. On that trial, they simply look in retrospective way. It wasn't a prospective randomized control trial. So they look at retrospective in all cancers, which assume to be early stage. And they look and they see after the surgery, how many of them they have lymph node metastasis and local spread. So on that trial, they find quarter of the women who thought to be an early stage, they have really metastasis outside the uterus. And out of those, 12% they have lymph node metastasis. Now remember, that's 1987. And for that reason, the approach was every woman with endometrial cancer to have a full lymphadenectomy. But remember, the aim from this study wasn't really to test if there is any therapeutic benefit, is there any increase in survival rate, is there any decrease in recurrence rate by doing lymphadenectomy. And that was the approach until late 2009, 2010, when there's 2 important randomized controlled trials about lymphadenectomy in endometrial cancer published. The first one is the ASTIC trial. I'm sure you're familiar with the ASTIC trial. And on that trial, they find pelvic lymphadenectomy did not really increase survival at all. And they said pelvic lymphadenectomy cannot be recommended as a routine procedure. And the second trial, the year after that, also the conclusion was doing a full pelvic lymphadenectomy will not increase overall survival. Now, despite these 2 trials were a randomized controlled trial, similar to the LAC trial, which I shared with you earlier, but these 2 trials, they failed to change any of our practice. So we're doing lymphadenectomy. And the reason is these trials been criticized hugely by the gynae-onc community. The sample size was small. It wasn't powered enough to answer the question. The surgeon who did the surgery, they're not trained enough. There's no enough lymph node removed, et cetera, et cetera, et cetera. And I think this is a lesson for all of us who are doing research and clinical trial. If you're doing a clinical trial which is going to answer a very big question, I think you have to design it very well and properly. Anyhow, so that's the outcome for now. And to answer that question, there is currently two randomized controlled trials. This one, the first one, CIPAL, which is due to finish recruiting patients in 2025. And remember, after that, they have to wait for 5 years to check overall survival. So you can expect an outcome 2030. And the other trial is the ECLAT, which Her protocol published in 2021. We are in James's part of this trial, due to finish recruiting 2027, so maybe 2033 or 34, we will have some sort of outcome. I'm sure I'll be retired at that stage, and maybe my son or somebody else will be doing that job. So what is accepted now in most of the gynae-onc centers is that lymphadenectomy in endometrial cancer, you can avoid it if the patient has an endometrioid cancer, a grade 1, and no myometrial invasion. And if you really want to push the powder a little bit, if there is myometrial invasion, it should be less than 50%. And that is taking me to the next step, which is the sentinel lymphadenectomy. And this is what we do in our center in James's, which we find is a middle ground between not to do lymphadenectomy and to do a full lymphadenectomy. So the sentinel lymphadenectomy, the sentinel lymph node, how you define it as the first node draining the tumor. It doesn't matter where that tumor is. And because that node is the first one draining the tumor, so, common sense, it should be the higher node, the node at higher risk of harboring metastasis. And you can pick up these sentinel nodes through different methods. Blue dye, either methylene or patent blue. You can do it with technetium-99. The problem with technetium is expensive. The injection should be done while the patient is awake, which is painful. I have a personal experience myself. It's extremely painful. I don't wish it to any patient. And you need a radioisotope department, your nuclear medicine department in your hospital. The most accepted and used method of sentinel lymph node is ICG, indocyanine green, which is quite cheap. All what you need is the injection itself, a syringe, and a speculum. And the usual laparoscope most of you use, you just need to upgrade it to infrared, which is not very expensive. And it's very simple. You inject the dye on the cervix at 3 and 9 o'clock, and you don't have to wait too long, because with the technetium, you have to wait. With the ICG, you don't have to wait. So within 20 minutes, you'll find your node is already stained with the green, and you progress your surgery. There's other method of delivering the dye, so you can deliver through the hysteroscope, you can deliver through laparoscope, subserosal, but again, there is enough evidence to say the positive predictive value in picking up the sentinel node through the cervix is as good as other method. So sentinel lymph node is very well established in other cancers, like with our colleagues with breast cancer and melanoma. They don't even mention the word full lymphadenectomy. Their practice is just doing sentinel lymph node. And it has been introduced to gynae-onc, mainly in endometrial, and to some extent into cervical cancer. Now, this is a very short video, and it happened for the same patient. So on the right-hand side, this woman had a full lymphadenectomy. And on the right side, she had a sentinel lymphadenectomy. And you see the sentinel, you have a very nice anatomy. You have the ureter here, easily seen. You see the external iliac vein. And here you see the uterine artery. You remember that famous things, water under the bridge? So here's the bridge, and here's the water. And you see the lymphatic channel going with the parametrium alongside the uterine artery all the way to the lymph node. And all what you need to do is just pick up that green node and take it out. If you look on the left-hand side, the dissection is way more aggressive. You're opening all the space, and you see all the anatomy. So way much more conservative on the left-hand side compared to the right. And the thing is, here's the result after 6 months. So you have on the right-hand side, nice thin legs, and you have a lymphedema on the right-hand side. And as I said, there's plenty of studies. I'm not going to go through detail because of the time, but this tested it with the low-grade endometrial cancer, with the carcinomosarcoma, with the serous uterine cancer, and even with the clear cell cancer, which is a quite very aggressive endometrial cancer. So all these trials, it did show that sentinel lymphadenectomy is quite safe, and the oncology outcome as good as a full lymphadenectomy. Now, if you're going to do a sentinel lymph node, you have to follow a certain algorithm. So the first one, you have to do a full inspection of the peritoneal cavity. If you find disease like this in the serosa, on the ovary, and the uterus, there's no point to do any lymphadenectomy. There's no even point to do any surgery, so you have to cancel it. You have to open the pelvic side wall, identify your sentinel node, and make sure you take the first one, not the second or the third one. If there's any enlarged node like this one, again, you forget about the sentinel node, and you take the big node, regardless if it's a green or blue or red. It doesn't make a huge difference. And like on the first example, if you cannot identify the sentinel lymph node, then you have to do a full lymphadenectomy. And the most important point is the last point. If you're going to do a sentinel node, you have to do ultrastaging for the node. Ultrastaging, quickly, what does it mean? Traditionally, the histopathologists, when they have a node, they just cut it from the middle and they apply H&E and they examine it. If you're going to do a sentinel node, you have to cut the node at very thin slices, 50 micrometer, anesthetic with immunohistochemistry to pick up what in new terms like isolated tumor cells and micro metastases. I'm sorry for the time. I will go quickly on the adjuvant treatment, which is really the interesting subject in endometrial cancer. So traditionally, we do adjuvant treatment based on clinical and pathological factors, age, grade, histology, and depth of invasion. So endometrial cancer is regarded as low, intermediate, high, and high risk. And basically, if the patient is a low risk, like stage 1A with no myometrial invasion, there'd be no need for any adjuvant treatment. You can discharge them. If the patient intermediate risk, like myometrial invasion more than 50%, or there's lymphovascular space invasion, you give them adjuvant vaginal vault brachytherapy. If they're high risk, you give them pelvic radiotherapy. And for stage 3, you give chemoradiation. Now, again, innovation, we're moving away from this. So the proposed and what's used in some centers for endometrial cancer, we classify it into 4 different types based on genetic and immunohistochemistry. So you have the first type where there's a mutation on DNA polymerase called Pol mutant, and they have an excellent prognosis. So the 5-year survival for these women is almost 100%. You have the second group, endometrial cancer with mismatch repair protein. Those, for example, patients with Lynch syndrome, they have this mismatch protein, and they have intermediate prognosis. And then you have P53 abnormality, where they have poor prognosis. They behave more or less like ovarian cancer. And if you cannot find anything, you call them no specific molecular profile. Again, for the sake of the time, I will share with you this trial, which was published just 4 weeks ago. And we in James, we were part of it. And on that trial, we look, traditionally, women with low stages, they have adjuvant vaginal brachytherapy for all of them. So that trial is randomized women into experimental arm or standard arm. With the experimental arm, we divide them into 3 groups, either low risk, intermediate risk, or high risk. With low risk, no treatment. With intermediate risk, vaginal vault brachytherapy, and with high risk, external beam radiotherapy. And the way to reach them is what I explained before. And here is the Kaplan-Meier curve for these groups. For the first group with the Pol mutation, it doesn't really matter if you give them or you didn't give them adjuvant treatment, they have an excellent prognosis. So we don't give them anything, really. On the second group, where they have mismatch protein deficiency, it makes a huge difference to give them adjuvant treatment, and it improves survival. Now, with patients with P53, it was the group who benefit most from the adjuvant treatment. And you see a huge difference between the blue, where there was no adjuvant treatment, and with the red, where you have external beam radiotherapy. And with the group where there's no specific changes, it was equivocal. So most of the guidelines these days, like the ISGO, the ESMO, and the American Radiation Therapy College, all these guys recommend incorporating the molecular subclassification of endometrial cancer and deciding on adjuvant treatment. And I'm sorry quickly for endometrial cancer in young patients, because I think it's important for our country. If a woman had endometrial cancer, it does not always mean you have to do a hysterectomy. These women, if they want to have kids, they can manage with progesterone, but you need the strict criteria to manage them safely. And at the end, I would just like to say thank you to every one of you, but also thank you to my team in James's and all the sponsors. Thank you.